Hi guys, it's Dr. Gillard. Today I put together a little PowerPoint presentation for you, and the slides from this presentation will be used on your Gross Anatomy 1 final. These will be the 4 extra credit potential points will come right from this presentation. So it would behoove you to study this, not to mention that this sort of stuff will be the foundation of your chiropractic career and the foundation of your diagnosis skills. So good stuff to learn. All right, let's get going. The objective is we're going to show you the basic anatomical structures of the upper extremity as demonstrated on a radiograph. What's a radiograph? Commonly known as an X-ray, although we don't call it an X-ray because X-rays are those ionizing radiation forms floating through the air, and we don't really hand people and look at those. We look at radiographs, so it's better to say that. So let's start with the shoulder. All right, so here's a radiograph of the shoulder, A to P, or from front to back. So first thing we can see here is the clavicle, which you can see right here. Okay, the clavicle meets this structure, which is the acromial process of the, don't forget to say of the scapula, right, for 50% off. This makes a very important joint right here. This is the AC joint, or acromial clavicular joint. Talk about the ligaments that hold that together in a little while. You can also see this structure running across here. See this? This is the spine of the scapula. The spine of the scapula. We can see a big knob right here. Remember in the last video we talked about when bone stacks on top of bone, it starts to show more weight. So you can see some type of projection here. This is the coracoid process of the scapula, which is a very important structure. We have a lot of ligaments that attach here. We'll go over those as well. You can also see a circular structure right here superimposed. Remember, x-rays like getting run over by a steamroller. It's not like CT or MRI where we have a slice by slice through the anatomy. All the anatomy is squished flat. So everything is superimposed upon everything else. So it makes it more difficult, I think, to look at than CT and MRI. This is the glenoid cavity right here of the scapula. Glenoid cavity comes off of there's actually a head of the scapula, gives rise to the glenoid cavity, and beneath that is the neck, is a little thick part beneath the glenoid, the neck, and we can have fractures through the neck and through the head. The head is very thin, but the neck is a little bit more beefy. Some older, well, I guess not older texts, I've seen it call this the lateral angle of the scapula, and you're thinking, well, I don't see any angle. Looks like it's a flat structure, and that's exactly what a lateral angle is. It's a truncated angle where the angle was maybe embryologically more pointy and it got squished flat. So, but it's better to call this the glenoid cavity, which comes off the head, which comes off the neck, which is this thick part right here underneath the glenoid. Now, here's what's the structure right here curling around? That's a posterior rib. You can see that quite nicely. You can actually count them. Here's rib 1 is always strange and really S to I, or depending on which way you look at it. It's got a slope that runs downward. So you can always tell rib 1 is here, rib 2 is here, here's rib 3, rib 4, rib 5, rib 6, rib 7. All this kind of weird cotton candy-like structures right here. This is all the lung tissue itself. Then we can see a line running right down here. See this line? So that's the vertebral border of the scapula, or the medial border of the scapula. We can see this one over here, kind of makes up the pit in the armpit region. That's the axillary border, or the lateral border of the scapula. Can't really see the inferior angle on this image. We can see the spine. Remember, here's the root of the scapula, would be right here. Okay, I think that takes care of that. And then now this is, of course, the humerus. This is the humeral head. We have if I could draw a line through here, and we have some slides coming up that'll be a little more specific, but that would be the what? That's the anatomical neck. So this is the head of the humerus, anatomical neck of the humerus. Right here is a surgical neck. Why do they call that the surgical neck? It's right at the base of this whole head kind of thing. Now that's because a lot of fractures happen right here, and that's where the axillary nerve is in close contact with this. And then we have a little, kind of a little shark fin right here. So that white means there's extra bone there. So that's the, what is that? It's the lesser tubercle. We have a greater tubercle right here. Lesser tubercle of the humerus. I don't call those the trochanter, that's for the femur. These are tubercles, which are not quite as massive as trochanters. And then we have in between here, intertubercular sulcus, or you can call it the bicipital groove. Remember the bicipital tendon, long head biceps tendon runs through here. It's covered by what? Ligament? Transverse humeral ligament. Okay, that's about all you can see. You can see this extra thick whiteness of the shaft here. This is the shaft of the humerus. That's the cortex, or the outer part of the bone. It's not where the bone marrow is, a little softer inside here, but this is really hard, so it turns up very radio opaque. Alright, I think we got that view covered. Let's see if this is going to behave. It slides down. Next slide down. Oh, look, I got a lot of little numbers for you, so you can quiz yourself right here. I think I covered all of these, so I don't need to talk about this slide, but you can take this quiz. So pause this, get out your paper, and take this quiz. And here comes the answers. And alright, let's just check in to make sure. Did I go over that little 9 structure right there? Conoid tubercle. That's probably the hardest one. The acromioclavicular joint, which has a ligament over it, right? Acromioclavicular ligament. I don't think that was on our list, but it really should be on our list because it's one of the key ligaments that blows out during AAC sprain. Okay, let's move to the next one. Let me give you a second, maybe pause the video right here. Take a look at this, see what you have, see what you can see. Pretend this is your 4 o'clock patient. You just finished the history, the examination, did your x-ray. Patient fell on her shoulder in a weird way. Severe pain. Didn't want to go to the ER, wanted to see you first. So what do you think? Alright, let's look at some orientation here. We got a lot going on here. She probably wouldn't come to you. She'd probably go to the ER, but you never know. Here's a clavicle again. Here's the acromial process. See something wrong here? Remember I told you in the lab how the clavicle is kind of spring-loaded? And if you rip these ligaments, what happens? It boing, it pops up. So this is a severe AC separation, acromioclavicular ligament sprain. Probably the most severe type. I won't get into the grading system. So we have an severe AC sprain. Let's check the humerus for any fractures, right? Any lucent lines. Looks pretty good. Okay, let's check the glenoid cavity. Uh-oh. See this right here? My mouse is covering it. That's right, that little lucent line, that's all you're going to get sometimes. And it goes right into the glenoid. So we got a fracture of the glenoid cavity, head and neck. The line, you can see the lucency, the lucent line goes right through here. So x-ray is a little tough to see sometimes, so check that out. Okay, we also have, looks like there's a fracture, not through the clavicle. See, the cortices are still intact. You can see those smoothly, but it looks like we have a fracture running right down through there. Okay, let's see, could be a fracture line here. Not 100% convinced. Sometimes big veins running through in the center of a bone can present like that. Okay, then we have the ribs coming around. Let's check the ribs. So we have another rib coming around like this. Looks good. We have another rib coming around like this. Looks good. Let's count them. There's rib 1, 2, 3, rib 4. Now follow these cortices on rib 4, the up and down borders. So look what we got here. We got a problem, right? Look, there's a huge disruption of the cortices here. That's right. So we have a fracture of rib number 1, 2, 3, 4, 5. Rib 5 is fractured. Rib 6 is fractured. Rib 7 is fractured, kind of the lateral, posterior lateral part of the rib. So good, rib fracture. Let's move on. There's just some arrows to help point those structures out. Alright, now here's just a little cartoon I threw up here. Remember these important ligaments. So we have the conoid ligament, which comes from the back. All of these come from various spots on the coracoid process. Trapezoid ligament, coracoacromial ligament, and this important one that you should add to your list, I think, for me anyway. Acromioclavicular ligament, very important there. Alright, let's start the elbow. So here's a to P view of the elbow. The elbow, of course, is made up by humerus connecting with the radius, good, and that's the big ulna, or the big ulna at this end anyway. So we have some structures. This is the one that sticks out like a sore thumb. If you run your hand down the medial part of your arm, you can feel it. It's often a little tender. It's almost like a coat hanger here. You can really feel it well here. So that's the medial epicondyle. Lateral epicondyle would be here. See this little loosened, or this radio opacity right here. Lateral epicondyle. We got a big hole here. So that's for this olecranon process. So this is the olecranon fossa. It's through here. The olecranon process is superimposed over, I guess you could call this just the condyle, which gives rise to the epicondyles. So you have to, it looks a little radiodense. You can see the lines of it here and here. Okay, and let's look at the radius here. So we got this big bump here. That's easy to mark, right? That's for the biceps, common tendon and biceps brachihooks in there. So that's the radial tuberosity. Radial tuberosity. Some older texts call it a tubercle, but tuberosity is probably a better name. So here's this big bump here. That's the head of the radius, the radial head. Here's the radial neck right here. So this would just be the shaft of the radius here. And then let's look at the ulna here. We have a divot right here. Okay, so that is the radial notch of the ulna in all these structures. Head of the radius, tuberosity of the radius, so the radial tuberosity. Don't forget to include that. Now you can't, when you flex your elbow, remember this head fits into a groove in here. Can't really see that groove. Same for this point right here. That's the coronoid process. Coronoid process. So there's a coronoid fossa here, and there's a radial fossa. You can't see those. You can see the vicinity of where they are, but you can see this knob right here. And then you can see this double knob right here. So that's the trochlea. This is the capitate, or I'm sorry, this is the capitulum. Capitulum. Trochlea is right here. Coronoid process is right here. Okay, so let's move on. Lots of numbers for you to take the little quiz. There's the answers to the quiz. Okay, so still on the elbow, this is a lateral view, nice lateral shot, 90 degrees here. So this is a decent projection here. So now you can see a nice notch here. So that's the trochlear notch. This whole piece right here would be the Ochronon process, all of this material. Here's the head of the radius again, shaft of the radius. It looks like there's a little bump right there. You can't really, it's not that impressive, but that is radial tuberosity. For attachment of the bicep tendon would attach in there. It's kind of in a weird angle here. It's back in there. Let's see what else you can see. I think we talked about everything else. This is the capitulum here. It's really, really dense bone, so it actually forms its own little markings here on the lateral film. Now there's two important things that you look for with fracture. If someone came in and hyperextended their elbow or they fell off their skateboard, got to look right here and right here. Because when the articular cartilage is damaged and bleeds inside, remember that articular cartilage we saw kind of making the joint airtight? When it bleeds, if there's something fractured inside the articular articular surface, like anything in here, and bleeds, you can get this sign right here. See this radiolucency? See, look at the density of this tissue. It's radio-opaque, it's denser, it's more white, and then you got this shadow here. So that's called the anterior fat pad sign, and that is not a good thing to see. If you see this anterior fat pad side, there's most likely a fracture in here somewhere. Probably a 75% chance. I forget what the exact number is, but there's a high chance that there's a fracture somewhere in the capitulum, the coronoid process, the ochronon, trochlea. Something's fractured somewhere. Maybe the head of the radius was fractured. I don't see any fracture on here, but I definitely see a fat pad sign. Some call this the sail sign because they think it looks like the sail of a sailboat, or the spinnaker sign. Spinnakers are those big balloon-like sails. So fat pad sign is not a good thing. If this patient came in with a fat pad sign and you couldn't see it on your x-rays, I would refer them to the ER just to be safe. There's another one that can pop up here in the back, posterior fat pad sign, which we don't have here really. That's 90%. I remember that number. It's 90% chance there's a fracture. So you might even have to do a CT or even a bone scan if it's really elusive. Here's the numbers. Let's see if I got everything. So shaft of the humerus here. I have these labeled too. This is the supracondylar ridge here. You can see another increased density of bone. They're superimposed upon the top, so you can't really tell if it's the medial or lateral. And so I think I got all this stuff covered. Okay. All right, let's take a look. Did I not give you the answer to these? No. Well, for these, you're going to have to be on your, let's go through them. Radial head here, radial neck, or neck of the radius. So that's the tuberosity, radial tuberosity, shaft of the radius, shaft of the ulna. Here's the ochronon process of the ulna. Number 4 here by itself, that's the coronoid process of the ulna. So this is the condylar fossa of the ulna. We talked about number 7. That is the, why is my mind blanking? I just told you capitulum. And that we said are superimposed supracondylar ridges. And that's the shaft of the humerus. Okay, take a look at this one now. Give you a second, pause it, look at it. Okay, you're back. So we got a spinnaker sign here or sail sign. Anterior fat pad is here. Not good. Uh-oh, we got a posterior fat pad sign here. That is really not good. So that means we got to look super close. So the head looks good. Let's check the coronoid process. Okay, there's a fracture right there. See that little soap bubble or that little lucency? I'll pull this away so you can see it. So this patient has a fractured coronoid process of the ulna. Can't tell. There's the capitulum here. Trochlea would be out superimposed out here. So it might even be fracture of the trochlea as well. Hard to tell. We need to look at the other images, which we didn't give you, but there's your hint. Okay, good job. There's the fat pad signs. Here's another one. Okay, there's a fat pad sign right there again, and there's a subtle one back here. So this one's a little bit tougher to see. Now I don't see that the elbow's not 90 degrees, so it makes me wonder. They must have had some type of trauma. So there is a fracture in here somewhere. And so I'm looking at there's the capitulum, the trochlea is outside of this through here. I don't see any fractures there. This looks a little funky though, doesn't it? Right? Here is so the elbow's rotated in this, right? Because now we got what's that bump? Radial tuberosity's down here on this image. So the elbow's a little not a perfect X-ray. They must have had some type of trauma. But my guess is there's a fracture in here somewhere, which is not, we just can't see it really that good on here, but something looks funky in here. So fat pad signs. And by the way, this did turn out to be a fracture, but it needed to be demonstrated on CT. There was a fracture through the neck here, but they had to order a CT on this one. Okay, moving to the hand and wrist on our journey. So this is obviously a hand, AP, or this is actually a PA view. Here's the fingers, phalanges, metacarpals, carpal bones. You can just see the radius, and you can see the ulna right here. There's the ulna styloid process. There's the styloid process of the radius. And we'll go, I think I got a better one to go through. So let's just look at these lines though. So these are the carpal bones. This is the distal row, distal row of carpals here, proximal row of carpals here. These spaces between are intracarpal joints. And now we have this. So this is the carpal metacarpal joints. This yellow line, number 4. Carpal metacarpal joints. Let's go through the numbers. So this is the metacarpal. So this is the phalange. That phalange is made up of 2 phalanxes. So I guess I'm not grading these anymore, but for my x-ray test, make sure you say this properly. This is a phalanx. So number 1 is a proximal phalanx of digit 1. It's the proximal phalanx of digit 1. This is the distal phalanx of digit 1. 2 phalanxes, which is not a word, then you call it phalange. So these are the phalanges of digit 1. Okay, got it? So phalanx, phalanges is plural. So number 8 is the interphalangeal joint. There's no pip and dip here, right? Because you only have 2 phalanges. Let's take a look. Here's number 2. So this is the middle phalanx of digit 2. Okay, proximal or distal phalanx of digit 2, proximal phalanx of digit 2. Now we have another line here. So these are the phalanges. This is the metatarsal. This is the metatarsal phalangeal joints. Metatarsal phalangeal joints. Okay, here's the pip and the dip. Proximal interphalangeal joint, distal interphalangeal joint. Where's the interphalangeal joint? There's no interphalangeal joint on any of the 4 digits. 2, 3, 4, and 5, no interphalangeal joint. Interphalangeal joint is just here. Oh, I gave you answers on this one. Okay, got that down. Let's go to the next one. In our hand to look at. Okay, let's look through it closely. Whenever I stick something up, maybe there's a fracture here. I don't see any fractures. And that's true. This is normal. That's not a fracture there. It's a little piece of a sesamoid bone. There's a sesamoid bone here. Just like on the great toe. Sesamoid bone here. No fractures. Okay, now let's look at the wrist itself. So, which way's lateral, which way's medial? You can see the thumb sticking out here. So that's the metatarsal, first metatarsal here. Shaft, here's the base of the first metatarsal. Remember, these are all bases. Sorry, metacarpal. I'm still thinking of the lower extremities. Metacarpals. These are the bases here down low. These are the shafts of the metatarsals, or metacarpals. Alright, so which way is lateral? Thumb is always lateral, so this is lateral. This is medial in the anatomical position. So this is the scaphoid. Lunate. Triquetrum is here and here. It's got a bone over the top of it. This is AP view. That's the pisiform. So this is the proximal row of carpals. Okay, this is the radius here. This is the ulna, but they call this joint right here the radiocarpal joint. Radiocarpal joint, or the wrist. I always thought it was just the radius, because the real articulations occur between the radius and the scaphoid and lunate. But I was reading in the new strand ring last night, they actually do include the disc. Remember, there's a cartilaginous disc right in here, so they do include this as the radioscaphoid or radiocarpal joint. Okay, so the distal row of carpals. So we have this one right here, and this is the trapezium. Remember my mnemonic for that? It's like if you always start with a scaphoid when you're naming, and then I always forget, so I have to hesitate. I say and that tells me it's the trapezium, if that makes sense. You also see a structure, big structure projecting out here. So here's the tubercle of the trapezium. That's important. That makes up kind of the carpal tunnel, makes up the lateral border of it. There's a not so impressive, there's a tubercle of the the scaphoid as well, but you can't see it quite as well, but it's right there. So, and then we have another little bone, trapezoid bone is right in here, not too well seen in this image. Okay, next is the captain of all the carpals, the capitate bone, and then we have the hamate is right here. Another big projection right here. You can see the density. That's the hook of the hamate. So the pisiform, the hook of the hamate, and the two tubercles here of the scaphoid trapezium, or the trapezium, that kind of forms the upper borders, or the lateral walls of the carpal tunnel. Okay, we went over those already. I think that's it. What's that right there? Styloid process of the ulna, styloid process of the radius. Okay, so take the quiz, pause this, see how you do. I remember to put the answers for you on this one. This one is always tough. Okay, now this is a lateral wrist. This is probably one of the toughest views that we have. That's why I saved it for last. So to make sure it's a good lateral, you got to make sure that the smaller ulna is superimposed over the fatter radius. The radius gets pretty thick down here, just the opposite at the other end, right? But down here the ulna gets slim, radius gets fat, and so we have good superimposition here. And you can see this structure right here is the styloid process of the ulna. Now the styloid process of the radius is here. See how it's superimposed over a big bone here? It looks like a Pac-Man. See kind of the C here? That's the lunate bone. You can see the distal articular surface of the lunate here, which has to be lined up nicely with the capitulum. So there's the capt and the capitulum. Looks a little funky on this one. Almost looks like there's another bone superimposed, but it's not. But this is an important joint here, and you can tell it's important. See the sclerosis that's happened here? Now that's pretty much normal, but there's a lot of pressure goes through this joint. So you can get fractures through this joint, and this is really a good view to see it on. Sometimes you'll miss it on the A to P or the P to A ham or even the oblique hand. So make sure you know this bone, this little Pac-Man looking bone, which is the lunate bone. Now another bone, well, let's do this one. So here, obviously sticking out is that's the shaft of the first metacarpal. Base of the first metacarpal is here. So first metacarpal connects to the trapezium. So this is all the trapezium. Nice view of the trapezium. Now the trapezium connects to the scaphoid. So here's the scaphoid right here exactly. And the waist of it would be here, and it goes down. And it superimposes the Pac-Man right here. See that superimposition? I drew this for you over here. And there's the waist of the scaphoid, which is commonly fractured. Remember we said in the lab it's a bad thing to get a scaphoid fracture. 10 to 20%, depending on who you read, of these scaphoid fractures will result in avascular necrosis, which is a fancy way to say death. So they'll have to go in and fuse the joint. So it's because it only has a single blood supply. It's a very strange carpal bone. But anyway, so there's the scaphoid. Now look closely. You can see another bone right here. That's the pisiform coming around. You can see its shadow here. That's the pisiform. So how do we know if we have a perfect lateral? Because the pisiform will not stick out over here. You shouldn't be able to see it. It should be just inside the scaphoid, just exactly like this. So this is actually a beautiful lateral image. Here's all the other carpal bones superimposed upon one another. And so, yep, that I think is about all I want to tell you there. Okay, you can work on those for a while. Go back and forth. You got to train your eyes to see this. For me, it wow, watch the pisiform when you do this. I can see it. It just pops right out in my mind. I'm a very visual learner, but you can see all these bones real nicely. These are the key bones. So a very important, clinically a very important set of radiographs here is this lateral view of the hand. Okay, then I added in the distal radius and ulna for your viewing pleasure. Even added some numbers there. You can tell where I'm going with this, so you can probably bet something like one of these is going to be on your final. Yeah, I really went overboard here, didn't I, with that? Alright, so let's take a look at this. I think this is our last slide. So this guy's got a little bit of malposition here, but that's, you see, nice sesame bone here. That's not a dislocation. They might have been kind of their finger or their IP might have been flexed a little bit. Okay, let's check for fractures. These look fine. That's fine as well. It's just kind of funky the way this patient was positioned. Okay, let's look through here. Looks good. Don't see any fractures of the ulna. There's a nice styloid process there. So this is a young patient. You can still see the epiphyseal plate where it was. I'm not going to go into that. I'll wait till you get to your real radiology classes, but that gets more confusing because they look like fractures. So you have to learn what these growth plates look like. Uh-oh, I see something now. Let's check this. Um, lunate looks fine. Okay, I see it. See it right here. That's a fracture. That little thing is a fracture. So this would be a sneaky one, right? Because I mean you can hallucinate lines all over the place. But this actually did turn out to be a fracture. It looks like we got a little soft tissue swelling here as well. See these lines here? And there's signs, there's fat pad signs here. I'm not going to get into all that, but this patient, and that's why it's hard without knowing the history. It's hard to see fractures. That's why this imaging, when you'll learn my mnemonics when we get to eighth quarter, and how to take a great history and evaluation, but you would pick this up more from the history. Swelling here of the wrist, can't, she's holding her wrist. They take this x-ray. Oblique would show it better, but I'm not going to go into all that. But there is a subtle fracture right through the neck of the scaphoid bone. So 10 to 20% chance this actually may die, the bone may die. Actually, the distal part would die because it only has a single blood source going through here. Okay, I think that is it. I helped you out there. I blew it up. Looks a little better there. Alright, so thanks for watching and good luck on your final, and we will see you around the lab.